Good afternoon. Today I'll be taking care of Alexis, and she is a 49-year-old white female who presented to the ED with severe pain, rated a 9 out of 10, related to migraine with aura. The pain is concentrated behind her right eye and began approximately 3 days ago. She was diagnosed with migraine when she was 16, and her migraines typically appear just before or after her monthly period. She states that she has heavy periods and also has uterine fibroids. She's been seen by a neurologist to rule out other possible findings, and approximately 15 years ago, she was prescribed sumatriptan 100 milligrams PRN. The medication has always worked when she takes it at the onset of visual changes, but today the pain has continued to increase no matter what she's done. She's suffering from nausea and vomiting as well, and she has been admitted for pain management and observation, as well as for fluids to prevent further dehydration. Her current vitals are her blood pressure is 138/88, her respirations are 20, her pulse is 110, her oxygen saturation is 98%, and her temperature is 98.8 degrees Fahrenheit. Labs that are pertinent to this situation, her magnesium is 1.6 milligrams per deciliter, her zinc is 60 micrograms per deciliter, and her sodium is currently 149 milliequivalents per liter. The lab values and the vomiting are concerning. The vomiting has led to hypernatremia as evidenced by her sodium level, and this can cause confusion, seizures, and even death if it's left untreated. The low magnesium and zinc levels could be contributing to the migraine as a result of increased estrogen from her uterine fibroids and heavy period. Her blood pressure and pulse are elevated, but that's likely due to her level of pain, and that is expected. There are no assessment data currently missing from her chart. The findings that are consistent with migraine are the unilateral pain, the intensity of the pain, the presence of visual changes, which she has at the onset of the migraine, nausea and vomiting, and low magnesium and zinc levels. An abnormal finding is that the migraine has lasted more than 72 hours, since her migraines typically don't last more than an hour once she takes the sumatriptan. Additionally, high levels of sodium are not directly associated with migraine, but it is a result of the accompanying vomiting. She is at risk for becoming severely dehydrated, even more so than she currently is, and that could lead to worsening hypernatremia. She's also at risk for stroke due to the continued vasodilation that occurs during migraine. The patient needs include pain management, medication for the nausea, and immediate IV hydration. Her educational needs include the possible need for daily mineral supplementation and how best to manage the nausea and vomiting if they continue. She should be advised to seek treatment if the vomiting occurs for more than 2 to 3 hours to prevent additional dehydration and to keep it from getting any worse than it already is. The priority assessment finding is the hypernatremia that has resulted from the vomiting. If her sodium levels aren't decreased, the patient could be more at risk for severe complications. And again, that would be altered mental state, confusion, and even death. Seizures could occur as well. Second to address would be the magnesium and zinc levels, since those are potential causes for the migraine. And I'll get more into that in a minute with the research. The highest priority risk is increased hypernatremia because if the sodium levels are not restored to normal ranges, and that is 136 to 146 milliequivalents per liter, then the patient could suffer again from seizure, altered mental state, spasms, and even death. And right now, that is the biggest concern and what we should be most focused on. There is a research study, there's actually multiple research studies, but this one in particular proved that menstrual migraine can be caused by increased estrogen levels. And we all know that that's what happens at the onset and throughout the menstrual cycle. The increase in estrogen increases copper absorption, which then inhibits the absorption of zinc. Zinc is required to synthesize melatonin and CoQ10, and a decrease in those minerals is known to cause migraine. Additionally, an increase in estrogen, which again occurs during monthly menstruation, decreases magnesium and increases calcium absorption, and both of those have been shown to contribute to migraine as well. Research has shown that a disruption in the homeostasis of key minerals, including zinc and magnesium, can lead to production of free radicals, which is thought to contribute to migraine via oxidative stress, demyelination, and destruction of the sheath of the axons. The research proved that restoring mineral homeostasis rid the patients of migraine completely in this one particular case study. That was done by providing the patient with 75 milligrams of zinc just after breakfast every single day. I would anticipate orders from the provider for obviously normal saline to hydrate the patient and prevent further dehydration, IV pain medication, and Zofran or something similar for the nausea. Ideally, the patient would also receive magnesium and zinc supplements, but it's more likely that the provider is going to instruct the patient to take those at home. To implement the plan with members of the healthcare team and patient, I would ensure the patient receives orders for fluids and pain medication from the provider, possibly suggest an MRI to rule out anything except for migraine for this particular occurrence. Even though she's had an MRI in the past, there may be something new going on. And also ask for a consult with a nutritionist to assist the patient with taking magnesium, zinc supplements, any other supplements that she may need, and for ways to increase those minerals in her diet and maybe not have to take them in a supplement form. The priority orders would be the IV fluids and pain medication to prevent the patient from becoming more severely dehydrated and to alleviate the pain. The dehydration, again, is the biggest concern at this time and needs to be addressed before anything else. I would document the patient vitals, labs, pain level, history of present illness, previous interventions, and education that was provided to the patient, not only about what has happened, but about what potential causes of her migraine may be. I would incorporate the patient's needs and preferences by ensuring that I communicate the results of the labs with her and educate her on exactly what is happening the entire time she's in my care. And this may go beyond what the provider gives her as far as the IV fluids and the pain medication, and maybe even pointing her in the direction of some of this research that I have found to be helpful in maybe determining what is the root cause of her migraine. The orders for IV fluids and pain medication would not cause any conflict with any treatments or cause any risks. Neither is contraindicated with the sumatriptan that she took hours earlier. So it's been 3 days and her pain level has not subsided. She's not improving. She states her pain is now a 10 out of 10, whereas it being 9 out of 10 when she was admitted. At this point, it would be necessary for the provider to determine if a different pain medication would be appropriate, if additional imaging is necessary, or if there is some other underlying issue causing the increased pain. At this point, it's time to look beyond just the migraine and see if there is something else going on in her body that is causing the pain. I would expect that additional labs would be drawn to determine if the zinc and magnesium levels remain low, if the provider is aware that those are potential causes of the migraine, and if so, that the provider may request supplementation for the patient to see if the pain subsides as a result of the homeostasis being restored. The patient should be provided with 400 to 600 milligrams per day of magnesium, and based on the research, 75 milligrams of zinc per day in water just after breakfast. Hopefully, these interventions would alleviate the severe pain that she has and allow her to eventually be discharged without the severity of pain.